All right. Good afternoon, everyone, and welcome to the final session of this terrific conference on the role of generative AI and large language models in enhancing health equity. I don't think that we could let an important conference like this go by without the opportunity to talk about artificial intelligence and its implications for health equity. My name is Akin Demehin. I'm Senior Director for Public Policy at the American Hospital Association. I'm a black male wearing a navy suit and a light purple shirt because I'm a proud native Minnesotan. And I'm really looking forward to introducing you to our really august panel to hear about this important topic. This afternoon, we're going to be hearing from Dr. Ritu Agarwal, who is professor and co-director of the Center for Digital Health and AI at Johns Hopkins. Kenyon Crowley, who is managing director of data and artificial intelligence for health at Accenture Federal Services. Deelip, Mhaske, who is the Director of AI and Data Science for the National Minority Quality Forum. And last but certainly not least is Meagan Khau, who is Director of the Data Analytics and Research Group at the CMS Office of Minority Health. Just to very briefly orient you to the conversation, Dr. Agarwal will start by giving us kind of a broad overview of the landscape of AI and in particularly generative AI and some of the implications for health equity. Dr. Crowley will talk about the notion of responsible use of AI in the context of federal health programs. Deelip will talk to us about AI policies and their impacts on minority and populations that are hard to reach. And then finally, Meagan will close out with some remarks about unintended biases and some broader perspectives from her perspective. So, Dr. Agarwal.
Thank you, Akin. Good afternoon, everyone. It's a pleasure to be here, and I have a lot of content. It's very hard for me to restrain the professor in me. So pardon me if I go through these slides a little bit quickly. I am an Indian American woman wearing a black skirt and a black jacket, and my pronouns are she and hers. I'm going to start with just a little leaf out of Aditi Malik's playbook. Some of you may have heard her at the afternoon session. She made two observations. One, that health equity is a team sport. And second, that health equity is in the DNA of CMS. Let me just start by saying that health equity is very much in the DNA of the center that I direct, which is the Center for Digital Health and Artificial Intelligence. And it is also a team sport for us because we are a multidisciplinary group of researchers trying to unpack how artificial intelligence intersects with health equity and what we should be thinking about as a community of researchers, community of scholars, and a community of practitioners. So I'm going to be setting the stage for the rest of the panel, speak a little bit about the evolving landscape of a new, exciting, important, frankly dangerous and sometimes disturbing technology called generative AI, which many of you might have heard about. How many of you have played with ChatGPT 4? Okay, a fair number of hands, so you know a little bit about what I'm saying. I'll just briefly introduce the technology, talk about the issues and challenges that it poses for health equity, what might be some sources of bias in these large language models, and what are some mitigation strategies that are under development even as we speak. And I'll close by just looking ahead to the future of generative AI in health. So let's get started. You know, what is generative AI? Quite simply, these are deep learning models built on neural networks. They have the ability to create new content, as opposed to the predictive modeling that we've seen with a lot of the first generation AI, if I may call it that. These generative AI models can create new text, they can create code, they can create images, they can create videos. And they are trained on massive corpuses of data, as you're all aware. Some of them surf the internet all night, all day long to pick up every piece of information that's out there. And they're incredibly complex. Now, just to show you how red hot this technology is, please look at the chart on the right-hand side of the screen. It took ChatGPT just 5 days to get 1 million users, as compared with 3.5 years for Twitter. And I'm not well, 2 years for Twitter and 3.5 years for Netflix. So this technology is permeating our society very, very quickly. Two things to note about ChatGPT 4 and large language models in general. They are, yes, incredibly large, going from 345 million parameters to 1.4 trillion parameters today. The second point to note is that this technology is in an evolutionary stage. It changes by the minute, by the hour, by the day. New features are added, new information is added, new data is added, and the developers of these technologies add new capabilities. So it's almost overwhelming and hard to keep up with the pace at which this technology is changing, which creates a lot of challenges as we are trying to get our arms around it and figure out what guardrails we need. So if we step back and ask ourselves, well, how can generative AI address some of the persistent and systemic problems that we have discussed over these last 2 days with our healthcare system? There are many robust and promising opportunities for Gen AI to play a positive role in healthcare. And on this slide, I just list a few areas where generative AI could help with addressing some of the issues and challenges of healthcare. Specifically, I point out that Gen AI can help with patient care by promoting health literacy, allowing patients to learn about diseases and symptoms and conditions, allowing them to navigate complex collections of data. Gen AI can also help physicians with research by summarizing all of the clinical literature and all of the research literature that comes out, assisting with scientific writing. And then finally, Gen AI is predicted to have a major impact on medical education. There were many discussions today about medical education. What do we need to be teaching the next generation of MDs? Well, certainly facility with digital technologies is a big piece of that education, but with Gen AI tools, understanding how to work with those tools, what kinds of questions to ask, how to engineer the prompts is also going to be part of the key skill set that our doctors need in the future. Now, opportunities always come hand in glove with risks, and I don't have the time here to get into all of the risks that digital technologies and AI pose when they intersect with healthcare practice and delivery, patient autonomy, incorrect diagnoses, privacy and security, the list goes on and on. My focus today will be on the amplification of bias and how generative AI tools can amplify systemic, structural, cognitive biases that are pervasive in our healthcare system and that are pervasive in our society. So let's take a look at the sources of these biases and what kinds of consequences they have, as well as some mitigation strategies. So one big piece of the bias in generative AI comes from the underlying training data. First of all, we know that a lot of the text in the world is generated by majority populations. So if you just look at who the editors are, who the writers are, who the journalists are, who are the people who are producing content, they typically tend to come from majority populations. And therefore, their voices are the ones that these systems are being trained on. Minority and marginalized populations write less frequently for the types of publications that are used as training data in these models, so we have a real problem with demographic representation. We also have, of course, racial and gender bias that is in the training text, and I'll show you a couple of examples to illustrate what I mean. If you look at the table on the right-hand side, and regrettably I don't have a pointer, but I'll draw you, so this is an analysis of text in a corpus of speech on Reddit. If you look at the left-hand side of the table, the third row shows you judgment of appearance, and that appears as number 3 in the list of things associated with women and number 40 in the list of things associated with men. In the next part of the table, look at power and organizing. It appears number 61 in the list of things associated with women and number 1 in the list of things associated with men. Now, if that's not disturbing, I don't know what is. Here's an example of a prompt given to a generative AI where the AI was asked to generate a reference letter for a man and a woman in exactly the same circumstance. A 22-year-old female student or a 22-year-old male student. I have highlighted here the keywords in the female student's description: interpersonal skills, teamwork, well-liked member, and those in the male description: engineering-related leadership skills, well-rounded personality, natural leader, and role model. So the woman was warm-hearted, friendly, likable. The man was a role model. And these are the data that the generative AI is being trained on. So what are the consequences of this data bias? There's both representational harm, where certain groups get represented in certain ways, or they are completely ignored, or there are some racial stereotypes and gender stereotypes that are amplified in the data. And there's allocative harm, such that jobs are disproportionately allocated to men and women based on the kind of reference letter that I showed you, and health access, treatment plans, and other types of healthcare resources are also disproportionately distributed. Here's an example of a recent study that came out in The Lancet just last month, and this study examined the effectiveness of ChatGPT-4 to perpetuate racial and gender biases. And I'll just read out a couple of important sentences from this paper. GPT-4 exhibits subtle but systemic signs of bias, and there were significant differences in diagnosis and treatment recommendations based on race and gender. So what the researchers did was they just simply changed exact same patient description, exact same clinical scenario, and they just changed the race and gender, and ChatGPT-4 came up with completely different recommendations. So I hope you agree that, we have a problem that we need to fix and be very vigilant to. So of course, the research community and some of the developers of these technologies have been working on a series of mechanisms to address generative AI biases. And I realize that I don't have enough time to get deep into each one of these, so I'll just give you a very quick and brief preview of a list of bias mitigation strategies. So the first one of these is called retrieval augmented generation, where if you look on the right-hand side, essentially what this technique is trying to do is to say, well, we've got this general purpose tool that's trained on every piece of information it can grab from wherever it can grab from. Well, why don't we give it some domain-specific information? So on the right-hand side, you see a knowledge base which has disease guidelines, treatment introductions, clinical papers, and other related materials that are specific to the healthcare domain. And that way we can build more trust in the kind of output, because the user's query is sent first to this retrieval augmented generation engine before it comes back with a response for the user, which is hopefully a more reliable and trustworthy response. A second method is prompt engineering, and this is a really nice example, so follow along with me. So suppose I want to generate a picture which says, here's a nurse wearing a blue smock who is offering words of encouragement to a patient in an ICU. That's the prompt on the left-hand side. I also tell my LLM that, hey, the demographic ratio of different races in the United States is as follows: Hispanic 18.5%, Black, et cetera, et cetera, et cetera. And then what the LLM does is it takes this information and it generates prompts such that the resulting images that I'm getting on the right-hand side of the screen adequately and appropriately reflect the demographic representation of the nurses as are present in the population. So this is another trick to reduce bias. And then finally, post-training filtering is another method. This is another great example, but running out of time here. So now let me turn to the bright side of generative AI. I've identified a whole list of biases, proposed some mitigation strategies. How can we use Gen AI as a tool for good in health and medicine? Well, we know that there is a data deficit in medicine. We know that marginalized population are less frequently represented in genome-wise association databases, in electronic health record data. We know that information about them is sparse. We know we don't have enough medical images about them. Well, we can apply generative AI to generate synthetic data that is of high fidelity and high quality, so we can augment the data sets that we have and then be able to build downstream prediction models that are much more applicable and representative and can apply and be used for larger populations. All right, so today we have a lot of expansion going on in the large language model space with health-specific modeling that's focusing on training these large language models with different collections of health data. And there are a number of health-specific modeling approaches as well that I'm going to breeze by. Many tools available in the market. BERT-based models, BioGPT, that some of you may have heard about, which was based on an earlier version of GPT. And then the most recent and interesting tool here, Gatortron, which was developed out of the University of Florida and NVIDIA. And the nice thing about Gatortron is that it was actually trained on clinical notes. So many of the expertise-based and heuristic insights from the clinicians are captured in this Gatortron tool, and it can serve as an important site of insights about diseases and conditions and treatments. And of course, we have a lot of state-of-the-art health foundation models today. Specifically, the MedPalm family of models is tailored to healthcare problems and does offer some robust opportunities for future development for health applications in generative AI. So I'll just conclude by making a couple of points that there are robust opportunities for generative AI in health if and only if we have appropriate guardrails and regulation in place. And my colleague Kenyon is going to speak about some of those guardrails and regulations in his words, in his talk. I think the best use of generative AI is, on the one hand, to empower patients and clinicians, and on the other, to proactively mitigate and address biases that are so pervasive in the healthcare system. So thank you, and let me hand it over to Kenyon.
All right. Thank you, Ritu. And good afternoon, everyone. Thank you for staying with us as we talk about one of the most exciting areas in health and in innovation and technology right now. So again, I'm Kenyon Crowley. I'm a health information scientist. I've worked on issues of health equity and data science and behavioral science for probably the last 20 years. Actually used to work with Dr. Agarwal here, but now having a good time leading innovation in federal health, and so spending a lot of time figuring out how can we roll out these technologies but do it in a responsible way that's not biasing individuals and is helping us get the promise of ingenuity in federal agencies. So to further set this stage, there's two very important policies that have come out in the last year. The executive order on safe, secure, trustworthy development and use of responsible AI, and then the accompanying OMB guidance for governance, innovation, risk management for agency use of AI, but these days it's called the IP memo. And that draft guidance came out in the fall, and then in March, the final guidance was issued, and that's creating a variety of requirements for not only CMS, but all federal agencies in their adoption of AI. But this is not the first AI policy. In fact, for the last many years, since 2016, and even beyond that, but starting in 2016, there's been major legislation, major effort, both at the executive branch and legislative branch to support innovation and responsibleness with AI. Besides these two orders, in the last year, the NIST, National Institute for Standards and Technology, has put out their AI risk management framework and playbook. And this provides some robust measures and techniques that one can use to support responsible AI, to measure risk, to monitor risk, to help to build these programs. And in fact, that's serving as the basis for many of the responsible AI assessments that are being implemented today. So what's in the OMB guidance? So there's a lot, but I'm going to focus on three areas that federal agencies are being required to do. So governance, is at the center. This includes getting a chief A officer in place and publishing a compliance plan to meet the requirements of the OMB memo. There's an innovation element in which all agencies must publish their inventory of AI use cases. And some of you might remember this is not actually new. I mean, stemming from the Evidence Act several years ago, AI use case inventories have been required, but there's new requirements for the depth and robustness of those inventories and the types of information one has to share. And for federal health agencies, understanding if there are biases in one's models and one's AI would need being able to show how that was assessed as part of that inventory. And then being able to identify if there's gaps in the workforce or the data or the training or other tools. And then risk management includes implementing a minimum set of practices for the rights and safety impacting AI. So when we talk about rights impacting AI, this is AI that can influence a decision that may influence one's civil rights or one's access to government services. Things like education, housing, and healthcare fall within this category. And we talk about safety impacting AI. This is AI that may impact the safety, the well-being of individuals, and covers things like critical infrastructure. So AI that may operate a dam, for example. Oops. Okay, I'm going to transition now to talk a little bit more about Gen AI and how it's being used, how it could be used, and then we're going to circle back for how we juxtapose that with risk assessment according to the OMB. I know Ritu's already talked about some of the application types, but just to take it from another lens, so generative AI is being used to advise, create, assist, automate, and protect. And I won't go into each of these, but I think it's important to note that AI is not just simple tasks anymore. AI has passed the bar exam. AI has passed medical exams. Accountants use AI now to do their taxes. I mean, I've used AI when I need to decipher a procurement vehicle, but there's a lot happening here. And on this next slide, taking that model, thinking about what this might mean for CMS and in the context of health equity as well. And this isn't any CMS official documentation. This is just Kenyon's representation of that. So Meagan wanted me to be sure I do that.
I forgot the disclaimer. The views expressed were only my own.
Yes.
And not those of CMS.
Okay. Yes. And I might be a little bit late to the party on this, but I'm wearing a gray blazer. I'm a Caucasian male, almost 50, wearing a white shirt. Okay. So what I'll point out here is three primary areas when we think about where Gen AI can create value at CMS. And as was mentioned by other speakers, there's a lot of reporting that goes on. There's a lot of measures that are put out. How do we synthesize that information and make it digestible for different audiences, whether that's a provider or a beneficiary or even partners at the state and local level to understand and implement that guidance? Generative AI can be helpful for that type of reporting. Being able to communicate effectively with patients. Personalized patient communication is becoming a mature Gen AI use case. So we know that people have different health literacy, different quantitative literacy, different ways of understanding their health and wellness. AI can sense those types of attributes and then be able to tailor that communication to resonate with different audiences, which I think is a very exciting area and something that the research focuses on. And in health equity reporting, there's so many different dimensions, from social determinants to clinical information to other things that are happening in a community with the environment. Being able to take that information and bring it together to build health equity databases and health equity research sources is another, I think, good area for Gen AI at the intersection of health equity. But within these potential ideas to use generative AI, responsible AI must be at the core of any of these programs. So what is responsible AI? We mean taking intentional actions to design, deploy, and use AI to create value and build trust by protecting from the potential risk of AI. So what are these potential risks? And Ritu spoke about some of these risks, and here's a few more, and there's some similarities. We need to think about things like, is IP being infringed, or content being reused without permission? A primary risk in generative AI is prompt hacking. So are individuals engineering prompts such that the AI is producing nefarious or wrong or answers that may not be correct? And are there bias questions and answers? right? So, I mean, Ritu mentioned within some of the underlying data sets that power these generative AI models, these were built, or these were generated in an age when there may have been biases in society, or when there were biases in society, and these can be picked up within models going forward. So being able to put in place ways to detect that and adjust for that is part of being responsible in one's deployment of AI. Now, we don't have time to go into all the mitigation strategies today, but you can think about AI in a chain or in a process flow. And at each chain in that process, there's certain risks that may occur, but there's also certain technical controls one could implement to sense if there are problems within the activity at that element in the chain, and then correct for those, such as removing PII at one part of the chain, or running a model to see if there is toxic language being used at that part of the chain. So when you think about a well-orchestrated solution, it runs the whole length. And the other part of that solution that is key is humans, right? And having humans in the loop. We can't let AI run unchecked, but part of the interesting question is, at what point do you strategically put humans in the loop, and how do you partner humans with AI to get the most value from that AI? Because there's government folks here. You might agree that there's some aspects in administration that may be able to be a bit monotonous, and that maybe the AI can help. But we need to find ways so that the expertise of individuals is focused on those areas when they can be where they can be most valuable, and let the machines do what machines do well. Counting things, organizing things, searching vast repositories of data to bring information back in a way that's consumable. Oops, I did that again. Okay. So next in rolling out this responsible AI as an organization, there are several things one should consider, and I'd urge you to consider. So AI governance and principles is at the heart of a responsible AI program. And you'll notice that the number one thing to think about is human by design. And what that means, think about what impact would the AI have on a human? Are human considerations for different and diverse groups being considered in even designing the questions and the functions for which that AI is responding to? And also, and as I mentioned before, where in the design and the deployment are humans being integrated in that process so that they're being empowered, not otherwise. Other key principles is fairness. So understanding how models may be working well or not as well for different subgroups in a AI system. That's especially important within health. We've seen some bad examples over the last decade in population health, where AI models weren't providing fair results for certain populations. And then 3, being able to transparently show how the AI is working, explain the AI, and having that accuracy. Now, we don't have time to go into all these, but I'll close on this slide by saying sustainability is a key issue. These AI models are using enormous amounts of energy, right? And so to be responsible in one's AI design is one architecting the solution to have the most efficient use of the tokens and the energy sources that are driving that AI. Different changes in how prompts are designed, which models are selected, which architecture is selected, can influence the power utilization and not only and the cost of these models. So taking that into account is part of responsible AI governance. I'll kind of, in the interest of time, I'll leave Deelip and Meagan with some time, but when you're setting up these programs, beyond the governance, conducting AI risk assessments is at the early stages. So this includes both quantitative assessments as well as qualitative assessments to understand how one's program maps to best practices in responsible AI. And then enabling systematic RAI processes. So when one is moving from a pilot to an enterprise scale of AI, do you have checks and balances in place that if there is model drift or AI is acting unexpectedly, are you able to identify that quickly and resolve it? And then in setting up responsible AI in an organization, one must consider the workforce impact. So is there ways that we are upskilling workers? Are we adjusting the jobs to work harmoniously with the AI, or we're not just trying to replace jobs with AI, which is an error. It's like how do we, again, best empower humans to work with AI and do that sustainably. And I won't drain this one, but this is from an actual healthcare organization's RAI journey. And the message that I want you to take away from this slide is you'll notice that in setting up AI governance, conducting AI risk assessments, enabling the RAI systemic RAI testing, we were able to design that all using the knowledge capital that NIST had put together in their AI risk management framework that was built using a robust set of like academics, government folks, industry folks. So I'll leave that as the takeaway for now. And as part of their journey, they're moving into the ongoing monitoring and compliance, but they've implemented the first 3 steps. Okay, the other thing I wanted to leave you with, which has been really exciting for me over the last year. So we implemented a synthetic data program using generative AI at NIH. And one of the reasons synthetic data is a promising target for generative AI, because we know that synthetic data can help preserve privacy. We know in certain subpopulations, data is scarce. So by using synthetic data, you can provide increased representation of those populations. So for some groups, it's very expensive to collect that data that may not allow for its collection. So being able to use synthetic data appropriately is an exciting area. So, and in this particular example, we were able to build a system that could produce clinical surveys that were needed for usability testing of downstream analytical applications. And why would you do that? So if you think about when you run a clinical study, I mean, there's a limited number of folks, right? You may have hundreds, and sometimes you may have thousands of folks, but it doesn't cover the full breadth and depth of possible phenotypes and differences among individuals. And if you're going to run a downstream system to analyze that population of individuals, without that breadth and depth, you don't necessarily know if your analytical systems downstream are working well. So this was a very limited, targeted use case for system testing. And at the end, we were able to develop 100 of these surveys in a few minutes. It's about 10 cents per survey, where in the previous example, it would take a testing analyst nearly a whole day to do 1 or 2 surveys because there are hundreds of questions. And I just wanted to share too, like how this works. So we're able to engineer the generative AI to take personas of individuals, including names, locations, gender, something about their clinical condition, and then answer the survey based upon that input. In this particular program, we used race-blind personas. But in other programs in health, race may be important or influencing the likelihood of a health condition. So some of the next stages of this work is doing some of the RAG that Ritu mentioned, using additional healthcare data like genomic data, electronic health record, clinical data to improve the robustness of the synthetic data. But in this particular example, which was also pretty interesting, we piloted a number of approaches. We took the ChatGPT, large parameter model, but we also took self-hosted smaller models and looked at how those differences between the models impacted both the effectiveness of the model, the efficiency, the realism of the results. And as you might expect, sort of the higher parameter models had a more realistic responses when generating the synthetic data. They used more resources in terms of the economics of it, but it was only slightly more. And so when you're deploying these models, you can think about the architecture decision. You can host them locally with smaller models, and sometimes that's perfectly fine for a certain use case. You don't need the 3 trillion parameter model. With this program, we did take a medical doctor to review all the clinical results to assess that, and there were some interesting anomalies. I mean, there was in some cases, this is an actual example where the models, it was asking about relatives' hair texture, and the model says, "I'm an AI model. I don't have any relatives. I can't tell you their hair texture," which I thought was kind of interesting. And then the equity considerations in this, we looked at what was the balance and the representation of different groups in the outputs, and there were differences in the representation of different genders, different urban, rural, different racial groups. And so thinking about deploying LLMs, there's also in that chain of activities being able to put in place decision rules beyond just the generative AI itself if you want to get a balanced representation. All right, getting my wrap up notice. I'm almost there. So this last, it's easy to get started with LLMs now. I mean, before one goes to enterprise scale, you want to skill the workforce, begin identifying AI experiments, but also need to be thinking about equity at each stage of building these programs. And then iterate, test, and learn. And when you have successes, be able to celebrate them and continue to build out cross-agency partnerships. I will stop there and then hand it over to Deelip.
Thank you very much. Okay, so I'm a student at Johns Hopkins, so I'm not going to contradict my professor here. So I'm going to be very briefly what Dr. Agarwal and Kenyon has mentioned, and the population I'm describing is the voice of me, my personal experiences. First, let me explain what NMQF is, National Minority Quality Forum. It was formed in 1998. It's based in DC. What we are trying to do is to increase the clinical participation for the minority population in the clinical trials and create some research-based data and advocate for that. So last month we had almost 500 experts throughout the country coming and talking about the theme of our event conference was we have data, now what? And that's where we started working with the various groups throughout the United States and across the globe. So we, at an NMQF, we have almost 5 billion data points and documents which have been for last 20 years matching to the CMS data too. We have enormous data and we are trying to build some AI models to predict minority populations' health, anything we can use. And we are partnering with those organizations which have been working in India, all over the world. So we want to see the global models for the minority populations here. I'm not going to go into the biases in what Dr. Agarwal said, but I want to share the story. I came to United States in 2004. My topic for the conference was the criminals by birth. In India, there were laws that by birth, certain community has to report to the police station as soon as you are born. You are registered as a criminal by legislatures. So it was a British law which was never repealed. And that's how I came to United States, eventually getting admission to the PhD program in the UPenn. But the story did not stop there. The first dentist which is for me was before I came in 2004 to the doctor, because in my village there was no dentist or no primary care. And I just remember that while doing my research. When I came here, I said, America is the best healthcare system. Everyone wants to be here. And I was placed in the Northeast Philadelphia Frederick Douglass School. I met so many individuals sharing the same exact story, same background. They never went to the dentist, never went to the psychiatrist or even the primary healthcare worker. Then I had an opportunity to work with the USDA, with the Indian American tribes in 10 states, American Samoa and other. Same stories. During this process, I was also working with the WHO in 2006 as an intern. And that time, the social determinants of health was just a talk into the World Health Organization's headquarters, which became later a really big part. So this is the group which I'm talking about. We don't have the identity. There is no data on us. 2016, when General Assembly at the United Nations, all the presidents and prime minister came, I got 2 minutes to talk about my populations. And I said, if my people who are from marginalized communities and people who don't have any kind of data, if they form a nation, it will be third largest nation in the world. And the health indicators will be the worst for take any illness, starting from tuberculosis, malaria, the preventable diseases which can be done. So that's the population I'm talking. And when we talk about the data and AI, and now I'm playing with the AI tools and algorithms, and I see there's a vast majority of people throughout the world, they are not part of the AI system or the infrastructure at all. And that's where people like us, NMQFs, we want to come on the stage and share our stories that there is the gap between the technological divide has been always there since there are billions of people without the internet access, and now we are talking about the AI. We have not yet received the internet accessibility in. You talk about any African country or anywhere. And that's what is reflecting in here in global legislative records all over the places. So North America, normally we have a lot of more than 116 legislation, executive orders, various policies, groups. And UK and European Union has been developing the good legislative frameworks. None of those actually address this population, which don't have data, who never had access to the healthcare traditionally. That's why there is a reason. But Northeast Philadelphia, where I used to work, is closed school now. The Frederick Douglass School, it was broken that time, and eventually it was because of the safety reason closed. So these are the communities we are talking about. That we don't have data. And the most of the policies are framed by worldwide legislators. They are directly affecting us. They are directly putting us in a survival mode. What if? And there is no one to voice that. And that's the legislature. Look at the no available data throughout the world. There are so many countries throughout the world that they don't have ability to collect data or be a part of that decision making. And the AI infrastructure and AI advocates and many universities, research institutes need to talk about this large divide. If we lose this population and not a part of the discussion, it's going to be really another catastrophe, which has been in every revolutions. If you talk about internet, modernity, technology, industrialization, every time this population has been always left behind, and we need to really frame policies and decisions around this population. The World Economic Forum 2003 was held in Mumbai, and that's where I got involved with them. And these are the generally World Economic Forum always talk about the marginalized communities. So what most of these 4 points are discussed by Dr. Agarwal as well as Kenyon in his talk. But first point, real world patterns of health equality and discriminations. There are no resource allocations is not there. Like I tried to build some programs in the Kenya with the minor health. We are struggling. They have huge data. They are using our data too, but there is no resources to address those discriminations and equality. So as I said, I don't want to step on Dr. Agarwal's presentation, but having a data for this population is must. It has to be addressed now. And these are certain policy worldwide patterns about the health equity. You need to have inclusive data, and that inclusiveness goes beyond your race. We normally tend to put Asians in the same category, but even in, Dr. Agarwal might know that even in India, there are like 6,000 languages, 6,000 different cultures, different speak. Sometimes I don't understand the language my neighboring state, Gujarat or Tamil Nadu, is speaking. They don't understand the culture, the patterns we eat or dress. Everything is different. And there are certain diseases like sickle cell anemia and the increasing cancer now. Since last 10 years, I have been watching. There are a lot of deaths in the particular communities. Villages just vanished. So now government has just realized that through World Health Organization. So equity, when AI talks about, it's not going to affect America or India. It's going to affect every human being on this planet, and that's where we had to address our policies and legislations. There, last 2 days, you have been listening a lot about it, but I just wanted to make point that there is a vast population which is not addressed in the talks. And thank you for the CMS and everyone to give the chance to us to be here to make a voice. But when I started my internship with WHO, the first job I had was the Human Rights Council as a human rights intern, and that's where I see health as a human right concepts everywhere, not just in US or UK. It should be treated as a human right concept for the AI too. And I think You all know that EU just passed last week, I guess, AI Act, which talked about the risk assessments and all that. I was really excited about that. I have been part of a lot of discussion at the United Nations on that part. But then I realized that in the Netherlands, there is an AI program that put the risk for the kids, 12-year-old kids, how much, what's their risk to be a criminal. That's what I came for the US in 2004. And now in 2024, we are talking about the communities, how they are criminal, based on their just pattern and the data and whatever their discussion pattern. So nothing has changed for the vast majority of people. 2004, I came for the criminals by birth for the vast majority. And here we are talking about same algorithms. Thank you so much. Sorry, no, Meagan. Sorry.
Good afternoon. I'm Meagan Khau, Asian woman, black hair, wearing a beige dress with a jean jacket and black shoes. So I'll round us out with the guiding principle to address the impact of algorithm bias on racial and ethnic disparities in health and healthcare. This is a paper that our sister agency, the Agency for Healthcare Research and Quality, released at the end of 2023. And that is the whole title of the paper. This work was conducted by a technical expert panel that included researcher from ARC, supporting Executive Order 14091, which was released in February of 2023 as a follow-up to the initial Executive Order 13985 to advance equity. The panel developed a conceptual framework to provide healthcare community with guiding principles to avoid any repeating errors when it comes to clinical algorithm. And a self-pop quiz for you all. If you've been listening to our three speakers here, see which one of these principles that they brought up in their presentation. The first one, the first principle of the framework is to promote health and healthcare equity during all healthcare algorithm life cycle phases. So keep in mind what is the goal in you developing the algorithm, in this case, advancing health equity. Ensure healthcare algorithms and their use are transparent and explainable. Can you share and explain the work that you do? Nothing to hide there, right? Authentically engage patients and communities during all healthcare algorithm lifecycle phases and earn trustworthiness. And we hear this theme throughout the last 2 days as well is, do you know the needs of your patient, of your communities, of your enrollee? And do they trust you to share their needs? Without knowing their needs, what is the point of your algorithm? What is it that you hope to achieve? Explicitly identify healthcare algorithmic fairness issues and trade-offs, right? So the data aspect, the training, what goes in, what will be coming out, and are you seeking the necessary feedback from the expert, a diverse group of experts, to make sure that your goal align with promoting and advancing health equity. And lastly, establish accountability for equity and fairness in outcomes from healthcare algorithms. Are there truly no bias? And if there is, what are you going to do about it? So make sure you're accountable for the work that you do, the algorithm you put together. What are the outcomes, and making sure that you don't lose sight of your number one, which is your goal. And lastly, we all come and do this work with our best and good intention, but we don't want to lose sight of when you get so wrapped up, especially when it comes to profit, you lose sight of your patients, the communities that you're trying to serve. So when and how information on race and ethnicity data should be used in medical AI, we are still working to improve our data collection on race and ethnicity. OMB just came out with a new standard as we presented yesterday, right? In order for us to get disaggregated data, to be able to identify individuals, for example, not just the Asian category, the Vietnamese, the Japanese, the Chinese, and making sure that we're capturing patients, enrollees at the level that we need to in order to provide targeted care. using predicted race and ethnicity probabilities as a factor in a tool to diagnose fairness in medical AI. What is it again? What is the goal that you're trying to achieve? And also make sure that you understand how using algorithms may lead to unintended bias outcomes, how to identify those biases before implementation, and what to do with them if you do discover these biases. And these are what our other three speakers have mentioned in, things that there are tools out there, but making sure that you double check, have oversight governance to make sure that to the extent that you can prevent those biases, you should look into them. Thank you.
Thank you. And I know that we are just about at time because in this room, we are actually going to be closing out the entire conference in about 1 minute. Let me thank our panelists for their incredible talks this afternoon and all of the rich information they provided. The thing that it leaves me with, candidly, is a sense of real hope. AI is complicated, but there are strategies available to begin to mitigate some of the potential unintended consequences and some of the biases involved with it. And I really appreciated Deelip's historical perspective on how differences and how data shows up really do have a through line throughout history. Thank you all very much. And thank you.